Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hello there, and welcome back to episode, I don't know the number, Dr. Ruhoy, Dr. Kaufman, and we're here to talk about everything we don't know about mycotoxin illness.
And just to clarify, everything we do not
Just
know.
us, right.
Right, because some people do know.
Some people do. Some people claim to know.
Right,
some people
that's true.
insist they know.
That's true.
I don't feel that I know.
Right, and I don't feel that I know either. And also to further clarify, we believe in it.
I was just going to say.
Yeah,
yes.
we do believe that mycotoxin has a detrimental effect for our patients.
Although I fully confess, I started out as a severe unbeliever, a major eye roller. When I practiced in New York and somebody would come in and say something about mycotoxin, I'd kind of like I'd sit there and say, okay, tell me more. And now I'm 100% convinced.
Yeah, I agree. Well, I mean, the fact is, molds are fungi. Do you say fungi or fungi?
Fungi, I think. I'm not sure.
Tomato. But molds are fungi.
I think it is fungi. You're probably
Is it
right.
fungi?
Whatever.
I don't know. So, and most of them live in harmony with us, right? So they're not
Right,
all
right.
toxic.
Right. So that's actually one of my
Yeah.
preambles. Okay.
Right.
So actually, let me back up. So what made me change my mind? What made me have steady vision instead of eye-rolling vision? I met enough patients who in the course of their history would say, I have brain fog, my POTS is terrible, I feel horrible, I take a vacation, I go to Hawaii, I feel completely better, I return home, and in one day, all my symptoms are back. And you hear that enough, and you start to say, there's something going on here.
Right.
And it's not just because they're on vacation and they have less anxiety or stress. I don't buy that at all.
Right. And we're assuming, of course, it's mold because it's the most common environmental exposure.
Right.
Right.
So your question is, or what I think you were saying is really important. There's mold everywhere. I mean, you and I are in Seattle.
Right.
It's a little
Lots
wet
of mold.
here, okay? The whole city is not teeming with mycotoxin illness. Conversely, Arizona, which has no rain and it's 145 degrees and et cetera, there's mold there and people also get sick there. So the first question to ask is, why doesn't everybody get mycotoxin illness?
Right.
So my answer, which I don't know if I'm right, but it's to me logical, is we evolved over tens of thousands of years with a miraculous liver that has detoxification pathways, because even back then people had mycotoxin and bad, nasty stuff in the environment, and in order to survive as a species, we evolved these detox mechanisms. So I'm constantly exposed to mold, and you're constantly exposed to mold. What I think is that in a reasonably healthy person who does not have multiple other pathologies going on, i.e. complex illness, their detox pathways keep up with the toxic load, the mycotoxin in acquisition.
Right.
Okay? So it's a constant back and forth thing. Whereas in our patients, they're so overwhelmed with chronic inflammatory illnesses that are doing so many things, causing so many problems, that the liver literally can't keep up, and therefore the mycotoxins build up and become a new problem. That's my theory.
I mean, I think it makes sense. And I think, in some respects, when you have chronic low-level exposures, it almost primes the immune system to just sort of like deal with it. And it gets used to dealing with it and however it deals with it. And certainly through the liver, because there is that acute toxicity syndrome if you are exposed to high concentrations of mycotoxins. I think aflatoxin has been associated with like acute liver failure if you're exposed to high concentrations. But I do think chronic low-level exposures, though, I say that knowing that I spent years while I was doing my dissertation and I was sort of traveling and speaking about the low levels of pharmaceutical residues I found in waterways, and everyone would say, oh, but it's just parts per trillion, parts per gazillion. It can't, that's minuscule, it can't have any effect. And my argument would always be, well, it's the cumulative exposure of parts per trillion over decades of life. And so it just seems like chronic low level exposure Well, that was used to be my argument, that it would accumulate over time and then cause disease. I'm saying that at least with mold, because it is so ubiquitous in the environment, that with chronic low-level exposure, we just sort of prime the body to sort of deal with it. And then as adults, we don't have mycotoxin toxicity.
Right.
So
Right. That's a really good point that you're making in terms of the chronic low-level exposure. So we are exposed that way, presumably, and we're okay. But our patients are most of the time exposed the same way, and they're not okay. And I think that's this glass overflowing image where you and I, or healthier people, keep up with detoxification and keep the levels down to a level of insignificance, whereas there's so much going on for those patients they can't do it. And so that doesn't require a high exposure level. That's what I'm trying to get at.
And it also lends itself to the idea that our patients are somewhat immunocompromised, right? Because as you know, classic teaching when we were in med school is that, mold exposure really is only a problem for the immunocompromised. Right.
Yes, but that teaching actually is referring to mold, fungal infection.
Oh, that's true.
Not really addressing mycotoxin. I don't think I heard one sentence about mycotoxin in medical
It doesn't include sort of the air exposure of the, because so the routes of exposure, so inhalation of spores, eating contaminated foods, mold contaminated foods.
Right.
So wasn't that? I mean, but isn't that
but
it was thought that
school,
immunocompromised?
When you're talking about immunocompromised, I think they're referring specifically to infection, like there's the latest news with this new fungal infection that's causing illness and death in ICUs and stuff.
Right.
That's not mycotoxin illness. That is fungus growing in the blood, usually on a foreign body like a catheter.
So fungal infections, right? Well,
or
that makes sense actually. So mold is just one form of fungi.
Right.
With so they're multicellular with their hyphae.
Right.
Am I pronouncing that word correctly?
Right. Yes.
I really have no business talking about this stuff.
Well, I think both of us aren't sure, but we know it's a problem. So the literature is real clear. People exposed to water-damaged buildings or sick structures, sick building syndrome, that's very real mycotoxin illness. I don't think anyone doubts that anymore. The question is, does that apply to low-level chronic exposure like we're talking about? And by that I mean, or they mean, you might not live in a water-damaged building the way you might think of it, with a roof that has a huge leak, but maybe there was a leak in your dishwasher or your washing machine or your hot water heater. The wall got wet, the sheetrock got wet, mold formed there, you don't really see it, and that's constantly feeding spores, it's really fungal spores, into the air through your cooling system. You're inhaling it, I'm inhaling it, we're okay, but take a patient with POTS, a septed patient, they're not going to be okay. That's the argument.
Right. And I think that it makes sense because we know that in our septed patients that there already is barrier dysfunction. We talk about this all the time, the barrier of the GI tract, the barrier of the respiratory tract, the blood-brain barrier. And we know that mycotoxins further destroy the ability of the barrier to be a barrier, to function as a barrier. And so there's clear exacerbations of underlying symptoms that had already existed.
Exactly. And actually one of the things that also got me to believe is when I kept treating somebody over and over and over and changed the drugs and things, we just would hit a wall, and I sort of say, all right, what am I missing? What else could be happening here? And then I would finally do mycotoxin testing, and bam, I'd get very positive tests back.
Speaking of testing,
I was afraid. I knew I fell into that. All right.
We were briefly discussing this before we started recording. So I'm interested to know what you think is the best testing.
All right. Well, let's preface it. This is a rabbit hole that's even possibly bigger than tick-borne infection, okay, for the same reasons. So there's several labs out there that do urine testing, looking for, they can identify the actual toxin, and then they have all these long names, spelled out names. And I use one of those labs usually. Why do I use that one and not another one? Just partly habit, partly I think they give me a little more information. The names of the labs, we can use names. Right? So there's Real-Time Labs. There's Great Plains, which is now renamed Mosaic for some reason. Vibrant does some mycotoxin illness. Those are the only ones I'm familiar with.
Yeah, those are the only ones I've used.
And the problem is, and again, credit to Andy Maxwell, he once, going through the same rabbit hole, he once had He did urine panel testing. I think this is right. Andy, correct us if I'm wrong. Correct me if I'm wrong. In people in his office, staff. Okay, so we got like 3 samples of urine from his staff, and the same staff, another 3 samples on the same day at the same time, and he sent them to the 3 labs and got completely different results.
Oh my gosh! With each lab?
Yes. So that's the scary part. I don't know what to do with that.
That's information I wish I did not know, because I rely on those labs and I make treatment decisions based on those labs.
So do I. So I use Great Plains, and we'll make decisions. And I have to say that I'll follow the results, and I see them improve as the patient tells me they're feeling better. That's why I end up continuing to do it this way.
Right. So, I mean, I sort of like the idea of identifying the toxin. It gives me at least, just in terms of the different forms of testing, which is antibody testing. There's the mass spec.
Right.
There's the tandem mass spec, which I think is slightly different, that goes along with the liquid chromatography. And again, I'm not a chemist, and I'm certainly not a lab person, so I could be saying this incorrectly. But then of course, there's the PCR and ELISA, which I don't know if any of those
But
labs
they're not
use.
doing that.
Yeah.
You're not doing
Okay.
that.
I like the idea of identifying the toxin, but if Andy found that the labs are not reliable, then I don't
Well,
really know where to go.
I mean,
from
it's
there.
the same thing in tick-borne infection.
True.
I mean, I have patients where I've sent blood to hygienics and blood to now T labs, which is a new lab, and they're completely different results. That's why we call it a rabbit hole.
Right. So back to clinical history, though, which is what we sort of always focus on. I mean, I agree with you. So there seems to be a clear exacerbation of patients' already underlying symptoms associated with at least one, if not all, of the septet diagnoses that seem to be worse when they are in usually their home, as you said, but sometimes in their workplace. And yet when they go elsewhere on vacation or visiting or a conference, they feel a whole lot better.
Right.
And so there clearly is some indoor exposure that is just flaring their symptoms. And if their labs do identify the toxin, then I think that's enough fodder for me to at least start a treatment plan. And if they respond to the treatment plan, great. And if they don't, we move on to something else.
Right.
But I do find treatment of it to be somewhat confusing. And then, of course, there's that whole school of thought, well, you need to move or you need to renovate.
Right. So again, Andy Maxwell, he gave this great talk at our mast cell meeting last year in New York. He talks about a mycotoxin sabbatical, which is moving away.
Yeah.
He's done all this geomapping, showing that everybody who lived in this area, the incidence of complaints that may or were attributable to mycotoxin was big, and if they moved away, they were better. I mean, he's got this beautiful presentation.
Well, there was that book that, what's the name of her book?
Is this Julie?
Yes.
Yeah.
What's the name of the book?
Oh, gosh. I don't remember.
Yeah. Shoot,
I
I'm
read
sorry,
it, but
Julie.
I can't remember the name.
I read it too.
2
It was
years ago,
great book.
It's a
But
great book.
I think that's, so to me, like that kind of testing, if you want to call it testing, and what you're describing that Andy was talking about, which I didn't attend the New York meeting, so I wasn't there for it. But, to me, that's the kind of, I think, objective, tangible story that I hang my hat on. Like if you tell me that you went somewhere like completely out of the realm of where you normally live and felt, sometimes it's like 100% better. It's like they feel like different people, but even, 80% better. And that's all I need to know. And let's sort of treat what might be exposure. But the idea is that you're going to have to like live out somewhere else.
Yeah. I mean, I have patients who go to Joshua Tree. They go to the desert to test it out, and then and this gets so complicated. And actually, Julie in that book talks about how, you can do that, but if you use the same sleeping bag, you might have a problem, or the same blanket or clothes. So I think it brings up another point, which I have no proof for, but this is what I think. I think there's 3 kinds of mycotoxin illness in our patients. Okay, there are patients who have inhaled or eaten spores, and those spores are generating mycotoxins, which are making them sick. Those are the ones we're testing. There are patients who walk into a room with mold, and they're like within minutes they're sick.
Yep.
Okay, those patients, I believe, are having a mast cell activation reaction to mold exposure, not the same as mycotoxin illness.
Right.
And then the third group are the patients that have both.
Right.
All right. And I've seen all 3. At least that's the only way I can explain it.
No, it makes perfect sense. I've seen all three as well. And we know that it provokes an immune response, right? So if you have underlying mast cell activation syndrome or underlying autoimmunity, frankly,
Right.
like exposure alone will just trigger those symptoms and make them worse. But you could have isolated mycotoxin toxicity for sure. And I think that, so inhalation, and actually I once read a report that even if you're exposed orally, so if you were to eat contaminated food products, that there's still respiratory mucosa findings. So it almost doesn't seem to matter somehow because of the barrier dysfunction. These mycotoxins and their metabolite, or I guess the mycotoxins are the metabolites of the spore, right? So they can traverse over different barriers and get into different organ systems and certainly different mucosal linings and cause lots of problems. I mean, in fact, Stephen always talks about mycosis fungoides. He must say those two words
all the time. So there is a third test or another kind of test, which I have no experience with, but I've followed some of the literature, and there's some very smart people who discuss it. It's discussed recently on our Masterminds listserv a lot, and that is testing the blood for antibodies to the toxin.
Right.
So the argument there is that looking for mycotoxin in the urine is not accurate because that's just kind of leftover stuff coming from food, and it doesn't mean you have mycotoxin illness. But if you do antibodies to the toxin, it indicates the current ongoing presence of toxin in the person's body. Unlike antibodies, let's say, to strep throat, that might just mean there was an old infection. That's the argument. I'm not saying it's right. I don't understand. I mean, I understand the argument, but I just don't know if it's right. And we'll get to treatment in a minute, but that argument or that testing platform leads to a completely different way of treating.
That's interesting to me because so I think just knowing that the antibody is present, I don't think is enough to actually label it a disease.
They do.
Okay.
They argue just the opposite. They say finding
because it's what
laboratory evidence in the urine means nothing.
But think about it. It's like anything that's ubiquitous in our environment, right? So we know it provokes an immune response. That's what it does, right? It triggers the inflammasomes to just sort of this whole inflammatory cascade with cytokines and chemokines, and so the fact that the adaptive immune system is triggered to create an antibody to it is not surprising because we know the innate immune system goes crazy at all these exposures. So I just feel like I feel like I haven't tested myself, and I feel like if I did, I would have antibodies.
I agree, and I don't know how long those antibodies remain positive after exposure. So that would be a key question. I mean, an obvious thing to do is take 50 people and do their blood and their urine at the same time and see if there's any correlation, and then treat them in some way and see what happens.
Right.
But I don't think those studies have ever been done.
So what are the symptoms of, beyond obviously triggering of mast cell activation syndrome, which we've talked about and its symptoms, what are the symptoms of mycotoxin toxicity? I mean, I find a lot of neurological symptoms, a lot of neuropsychiatric symptoms.
It's mostly neuro.
Yeah. I agree.
You're on.
Well, it's not the typical neural, so it's, I mean, I see a lot of sort of cognitive impairment for sure, a lot of emotional lability, and different kinds of dissociation and anhedonia, which I often see in a lot of neuroinflammatory diseases, just because of the alteration of not only immune function of the brain, but the level of inflammation that occurs. And definitely dizziness. A lot of mycotoxin toxicity patients report just feeling dizzy, feeling nauseous, getting headaches. Right. And certainly, as they progress in this illness, and if they're not treated appropriately, or at least earlier on, or they don't respond to treatment, they it's like almost they're sensitive to just the slightest thing. They can walk into a room and they're like, I have to get out.
And to further complicate the assessment of symptoms from mycotoxin illness, if it's a patient who is having mast cell degranulation from exposure, then you get all of the polysystem, multi-system inflammatory stuff from mast cell, and you have a mess of symptoms. A mess of symptoms.
Right.
But mostly it is neuropsych and cognitive brain fog type.
Right, which of course just complicates things because, patients will show up at another doctor's office or even another neurologist and we'll discuss like these symptoms of feeling, one patient once described that they didn't feel like they knew where they were, but yet if you ask them where they were, they could answer.
Right.
But they had this like weird surreal kind of feeling, like they just were in a dream kind
Yep.
of thing.
Yep.
And so this is what they had told, another doctor who was like, well, I don't know what to make of that.
Well,
And
I have a good psychiatrist for you. Yeah.
So yeah, and in fact, in the neurology research, there's been associations, although not definitive and certainly not conclusive, but where there's mycotoxin exposure and associations with certain diseases, like MS is one of them actually. I remember one article about mycotoxin and multiple sclerosis. So there can be real neurological consequences of chronic exposure, especially at higher levels. So if you have like obvious black mold in your home, clearly I think that these things need to be addressed, need to be treated, which actually brings, so there's one thing about treating the patient. I mean, do you go as far as telling them that they have to get one of these, companies to come in and sort of do mold removal or whatever they do? That's a lot of money. I mean, I feel badly
first
telling
I
people.
usually test the patient first. If they're positive, then yeah, we need to find out. It's kind of like mast cell. You need to find out what the trigger is. Step one is
Right.
removing the trigger. So they have to look. And it's very expensive. It's not definitive. There's a lot of scammy people out there doing it. So it's, you need to look for reliable people. There are ways to find those people, but it's a big deal. And then if they find it, remediation can cost tens of thousands of dollars. And if you ever look at your homeowner's insurance policy, most of them exclude mold
Yes.
and remediation.
Yeah, I know I have a lot of patients fighting with their
Right.
landlords over remediation and costs of it, and it's a hard fight. It's a hard fight to
Yeah,
win.
it's very hard.
Because unfortunately, the research is not, like I said, conclusive enough where really it can go into a courtroom, for example, and there be a clear delineation between I was fine, I moved in here, and now I'm not fine, and there was evidence of mold, and so therefore this is the cause of my illness. The research doesn't support that in a very definitive manner where anyone can make that argument. So it's a very hard fight, and and I feel badly for patients because they go through a lot.
It's a lot of money.
Yeah. And so I don't, do you go as far as telling them that they should remediate or they should move? Because I always, that's like telling them to like sell their house and move out.
On occasion, yes. I mean, I was going to just say this so it plays into what you're asking. Another potential clinical tip-off to mycotoxin illness, if your patient, your index patient, the person you're talking to, says, oh yeah, my kids are also kind of strange, they have all these problems, my husband just started having problems. So if you have a family that's got suspicious sounding neuropsych, cognitive brain fog type stuff, that makes me pretty suspicious. And I actually have a family I'm thinking of who are in Texas, and every time they leave their home, they're better, and every time they come back, and they've finally given up, and they're going to sell their home and move out.
Right.
So.
Yeah, it's such a drastic measure.
It's drastic, but
as opposed to just prescribing something. But I agree. I agree.
That's going to be our dangerous segue of what do we do?
What do you do? What do you do? I have to be honest, and I have to say that I do a couple of things that I know are part of like the mold protocol. I haven't found them all that helpful. So I take the approach of this is basically an immune response to an exposure. I mean, I do a lot of exposure medicine. That's what I call it now, exposure medicine. It's my own term. I don't even know if it's real. Yeah. But I just take my approach of like this is an inflammatory and immune response to an exposure, and I do much of what I do in general to any exposure, frankly.
Right.
So
for me, it's a work in progress. The typical, as you say, mold protocol involves these things that have this horrible name called binders.
Yeah.
That was a big eye roller too. Right? Someone told me they hate binders. And the concept is that there's a circulation in the liver and the hepatobiliary tract, and it gets reabsorbed. And if you take a binder, it stops the reabsorption and sucks out the mycotoxin.
Right.
I don't use most of what other people use, like cholestyramine and Welchol and charcoal, mostly because I think patients don't tolerate it and it interferes with their other medications absorption. I do use something from one of the supplement companies called Mycopol because it's easier to take and seems to work. But like you, my real focus would be on what can we do to improve the capacity and function of the detox pathways which are in the liver. And there really are pathways. This is not
there
a
are real
made-up
pathways.
concept.
Yeah.
So things like glutathione, which is
I love glutathione.
difficult to make it work, meaning, is it absorbed by mouth? It's not so easy to get IV. It's very expensive. But I do it, and I do think it helps. And anything else I can do to reduce inflammation and make that liver healthier. And that means,
I agree. And I think the detoxification pathways are interesting. And I think that we all hold certain polymorphisms that make our detox pathways different. And I don't want to say better or worse, but I'm always curious as to, and I think we talk about this a lot, but about why did, person A, why were they so severely affected and person B wasn't? Right. So I do some like genetic kind of analysis, genetic panels that focus in on detoxification pathways that can give me some clues. Because
Tell me more.
Well, I use what's called Intellex DNA, and I think I've told you about this. Yeah, Intellex DNA. They actually have some really nice panels that sort of focus in on certain detox pathways. I also, some of the pharmacogenetic testing that you can test will actually look at some of the liver enzymes specifically, as you know, because then you know what they metabolize with regard to certain classes of medications and how they metabolize it, and you can extrapolate from there about how their liver will handle detoxifying exposures such as mold and mycotoxins. So I do, and it obviously can get costly for some patients, but I do think that it helps me tailor my approach to patients, because I agree with you what you said about the binders. I don't find them well tolerated. I don't find them that effective. Right. I do prescribe some vasoactive intestinal peptide spray, which is part of the protocol as well, which does seem to help a lot of the neuropsych kind of symptoms. But interestingly, peptides like Cmax and Silank, I find them to be so effective for these patients, so effective. And I like the combination. They have a synergy. So I
have not done that. That's very interesting.
So effective. It's like a PANS presentation almost, right? So C-Link and C-Max do reduce the neuroinflammation from any cause, but really effective. And actually, as peptides go, I should say, really not that expensive. As you know, some peptides can be really costly, but these are nasal sprays and they're not that costly. So I very much incorporate peptides into my mold plan. Yeah.
So the other thing is optimizing or intensifying mast cell treatment.
Absolutely. Okay. So really focus.
Because I think that's a big piece of this that we're still just scratching the surface of understanding.
Yeah, I completely agree. Yeah. So, and I think any way that you can support detoxification. So even if it's just like a general approach to liver support, I find to be helpful to patients. And so I focus in on things that will help support the liver. I mean, I like milk thistle and things like that. Right. But, and I really do like glutathione. And if patients are local, we have them come in to do IV pushes of glutathione. You can obviously take liposomal glutathione, which is a little bit more bioavailable, or you can do the precursor N-acetylcysteine, which I find to be very effective, especially if you do higher dosages of it.
So have you ever used this combination of glycine and NAC, Glynac?
Mm-hmm. Yeah, I have. I find that I like that a lot. Yeah.
Well, I have to do that more.
Yeah. So I think all of those things really are very helpful. I know there's a very extensive mold treatment protocol, but beyond VIP spray and binders, I haven't tried any of it really.
Nor do I subscribe to the chromosomal checking that group does. I'm trying to think of the right label for what they do, but they look for certain HLA findings that they think increase the risk of mold toxicity.
I didn't even know that. Which HLAs?
I can't tell you.
Okay.
I mean, I used to know, and I've read it and looked at it, but I don't do it, and it's a whole bunch of stuff.
And is it known to be?
Well, there's a school that says it is, and there's a school that says it's not. I mean, one of the things we should do is probably try to bring on one of the other docs who do this more and know more. There's a few of them in masterminds that we could ask if they want to join us.
I completely agree. I mean, I sort of like our conversations about, just sort of being honest and transparent about what we know, what we don't know, what we're not sure of, and the fact that there's controversy, you know. And so I agree, though, we should bring on someone who's clearly much more well-versed than we are.
So, one other aspect of mold is to talk about is SIFO, small intestine.
Right. Oh, I was going to say that. Okay. So a lot of what I do in terms of treatment, because of its so it's been known, exposure to, I didn't mean to interrupt you, sorry, but exposure to mold and mycotoxins. actually has been shown to sort of to flare like inflammatory bowel diseases,
Right.
like Crohn's and ulcerative colitis. And so I always think about its role in the gut, and then so I'm regularly checking for SIBO and SIFO in these patients.
How do you check for SIFO?
Other than I just presume
think of it.
I think of
Yeah,
it is what I meant.
No, it's
But I
important
do
to
the
make that
SIBO
distinction.
testing.
There is no
Yeah.
test for SIFO short of, I guess, maybe putting a tube in there, but I
Right.
don't think
No,
anybody
exactly.
does that.
But I guess when I say that, when I test for SIBO, I'm thinking of SIFO too.
Right. So the question is, how do you determine if somebody has small intestine fungal overgrowth? The answer is you can't. There's no test that I'm aware of. Maybe there is, but I don't know about it. So to some degree, it's based on one of my favorite expressions, index of suspicion, and clinical thinking.
And
all right?
somewhat of a diagnosis of exclusion, would you
Right,
say?
yeah. So I would go at it two ways, and actually one of the ways you just told me about I have not done, but now I will be doing it because I think it's really interesting. So in treating SIBO patients who have hydrogen, methane, hydrogen sulfide 1, 2, or 3, or all of them at the same time, if they're not getting better, I will often say, maybe this is SIFO, let's do a trial of treatment, okay? And at this point, I think I should do what you're saying, which is anytime I see somebody with positive urine panel, it's probably reasonable to give them a trial of treatment, which would then, this is going to come out wrong, this would then keep the people who believe in the antibody testing happy because it's the same treatment.
Mm-hmm.
So I'm covering both sides of this coin or this knife, right?
Right.
Okay, what's the treatment? The treatment's very simple. It's using antifungal drugs. So the classic ones are fluconazole and itraconazole. They're called azoles. They are remarkably well tolerated. I've used doses of 800 milligrams of fluconazole for years in my HIV patients back in the old days, with total tolerance, right? They would be treated for cryptococcal meningitis,
right.
et cetera.
That's what I meant when I was referring to the classic teaching was immunocompromised patients, but you clarified what I should have been referring to. So I was thinking of the HIV population.
So 2 to 4 week trial of fluconazole or itraconazole. Does it help? I can't be sure.
So many patients say they feel great on fluconazole.
I have patients who absolutely say, and when they stop it, they feel worse.
Yeah. So,
So then I do it.
Yeah.
I think you and I say this all the time, and I think the audience, the viewer needs to appreciate so much of what we do is trial and error. Mm-hmm. So much of what we do is keeping an open mind to what does action A do? What's the outcome? If the outcome is good, maybe that's a reason to keep doing it or restart it if there's a return to action to previous symptom, which is very different from most of medicine. Mm-hmm. And that's, I think, one of the reasons we have trouble, we meaning chronic complex illness doctors, with mainstream medicine where, you treat strep with azithromycin or penicillin, nothing to discuss. You treat heart failure with whatever the latest drug of the day is, versus our necessary approach of trial and error and clinical guide, using the clinical outcome to guide our decision making.
Right.
Which is also why, as you know, I rant and rave about the whole evidence-based medicine guideline world, which is good. It's good to have evidence-based medicine, but if there's no evidence, that doesn't mean we should just give up on our patients.
I mean,
I know
you're preaching to the choir. I can't give up on people. I think that's actually somewhat of a flaw sometimes. And honestly, do you ever feel like the fact that you won't give up, is sometimes, not in their best interest because, you try all these different things. Yeah. Sometimes I worry that I'm just trying too many different things and that, maybe.
Sometimes I think I should give up in the sense of I need another pair of eyes, and that's why you get referrals from me, or, I need somebody to take a different approach.
Yeah, that's what I do.
But, the only time I, quote, give up is if it's sort of a terminal patient, but that's not the kind of patients we're talking about.
No.
And in fact, I very verbally tell patients that because they'll say, oh, I'm never going to get better. And my answer is, well, I'm not going to give up,
Yeah, no, I regularly say that because I know that I don't give up.
Right.
But I often wonder if that's sort of going to be, not in their best interest if I just sort of keep coming up with ideas of stuff to try. I don't know. I think patients seem to appreciate it, but.
Well, I think it's important to hear from your doctor that they're not going to give up.
Right.
It's not, so many patients come to me and the doctor would say and as they give their history and talk about all the physicians they've seen, so many times the doctor says, I can't help you. I don't know what to do for you.
Yeah. I've had doctors say that to me, and it's horrible to hear. It's horrible.
Yeah.
So I will never say that to a patient,
Right.
you
It's
know?
terrible.
So yeah, but I agree. So when they have a response, then I say, okay, let's optimize this. And I sort of go down the same sort of path, or at least thinking process that made me recommend what they were responding to. If they don't respond, then I completely, pivot
Right.
and sort of think, okay, well, let's test for this and let's try this and see if that works. And usually patients are on board because obviously everyone's motivated to get better.
I think a corollary to the I don't give up and to what we're talking about
Mm-hmm.
and what we were just saying about CFO and treating, and I know we both agree and we've said it before, but it bears repeating every time, is how much I end up learning from the patients in this regard. So, I told you before we started today, I had a patient yesterday. I was reading the record to prepare for my new patient visit, and this patient happened to be on a drug that I'd never heard of. And I was like, whoa, this is cool. I never heard of this drug. And I look it up. The drug is for something called periodic paralysis. And the patient I was seeing that day, different patient, has periodic paralysis. So suddenly I had a new thing I could offer. Turned out this patient was really smart, already knew about it. She teaches me endlessly. So, the point I'm making is not only are we dependent on trial and error, but I feel deeply dependent on the knowledge I get from patients. Whether it's references, did you see this article, or I tried this 9 years ago and actually it's the only thing that ever helped me.
I agree. I mean, I love when patients send me links to articles that they read.
It's overwhelming, but
they'll often say, you probably already saw this, and sometimes I haven't.
Yeah.
So I love it, because I like to keep up on things, and sometimes I would have never found that article that they sent me.
Right.
So I love the relationships that I have with patients, and I feel like I often will hang up with a patient and feel like, wow, what an honor it was. I know that sounds so ridiculous, right? But what an honor it was to talk to them, and that they've allowed me into their world. And so then I feel like I really want to help them. And it's a lot of what I talk about. I feel like we make, I think lots of doctors do. I still don't want to make it sound like,
No, I think I agree.
I hate to sound like I'm patting myself on the back, but I really feel like we make like good connections with patients just because we listen, we validate, we understand because we've seen it before, we've heard it before. And, I think it was just sort of part of their journey. And I don't know, I think that's an important, for humanity in general, I think that's important.
I think another aspect of this is, or another way of saying it or expressing it is, I feel like I'm always learning on the fly.
Yes.
Meaning, I'm not sitting down to study and read a paper. I'm learning.
I'm not in a classroom.
And as a perfect example, I realized as we're talking about CFO, and I need to more often start trialing itraconazole or fluconazole.
Yeah.
It's like a no-brainer, and I haven't been doing that. And now I've learned something today that's going to change how I practice.
See?
So
aren't you glad we're doing this podcast?
Yes. No, I mean it. I'm very serious.
What made me think about this whole topic, and I know it's obviously off the topic of mold and mycotoxins, was that what you were sort of saying when we started, like you were initially a non-believer.
Right.
And now you're a believer. And that is certainly applies to me as well. And so that's why I feel like this sense of like, I don't know, like this connection to patients, that I'm going to believe what they tell me, and I'm going to believe what we learned from our masterminds group.
Right.
And I'm going to believe it to be true, and I'm going to apply it to the patients, and then I'm going to sort of see how they respond. And so I feel like this is such a learning experience is my point, that I have come such a long way of like not really, I should say not understanding. I hate to say it, I didn't believe. I didn't understand.
Well, in hindsight, I didn't understand.
Yeah.
At the
So
time, I have to humbly confess, I just didn't believe.
Yeah.
Sorry.
But now I completely understand. Yeah.
And it's
sure.
again, it's this trial and error that we keep talking about. It's pivoting, it's responding, it's changing course.
Yeah. I'm always doing it. Always doing it, with the caveat that of what you always say, which is like, let's really give this like the college try before we decide it didn't work.
Well, right, a little bit more than 1 day or 2 days. So Julie's book.
Oh, Julie's book.
Through the Shadowland.
Through the Shadowlands.
Julie Raymeyer, Through the Shadowland. It's really
it's
good.
a fantastic book. I read it in one sitting.
Yeah. It's really good.
And it really does sort of prove the point of what we were saying, which is that if you remove yourself from your usual environment, you can have such a positive change in your health. And it really does confirm not only to your doctors, but to you, to the patient, that something in your home is making you sick, or something indoors is making you sick. And it doesn't mean that you could be in any indoor space, because in her book she even describes how when she went to other places, and she knew immediately when she walked into the air something about the air quality or the
Yeah.
air or an odor of the
No, I
of the
think it's when
building.
if I recall, would be when she went back to visit in Berkeley
Right,
or
right.
Oakland, she'd immediately get sick.
Right, exactly,
Yeah.
exactly. And there were times that she had to find a place for her to sleep and to
Right.
live where she could at least allow that exposure illness to sort of die down because she was no longer exposed, which of course speaks to number one, rule of any kind of exposure illness is to remove yourself from the exposure, which,
Right.
is sort of exposure 101, environmental medicine 101. You have to
Yeah.
remove the exposure, the trigger to expose to the illness, which is not easy to do sometimes. So, but yes, so that's her book. I'm sorry we couldn't remember it earlier. Or
Right. Yeah, so I think, the sort of takeaway here is it's mycotoxin illness is very real. Like tick-borne infection, the testing, the ability to test for it and prove it or diagnose it is problematic. That doesn't take away from its reality. And it only means we need to just be willing to try things if we have a clinical suspicion that's high enough to say, I think you should try this, or I think you should try that, or I think you should try both, or number one and then number two. And
Right.
There's just no other way to approach it.
I 100% agree. Like I said, I see it as an an aberrant immune response to an exposure, and because those are the symptoms.
Right.
So, and I treat it as such, for the most part. And I think about the different organ systems that can be involved and how I can support them and find other diagnoses like the SIBO,
Right.
and then the theoretical SIFO.
That's not theoretical.
No, I didn't mean theoretical in that whether or not it existed. I mean you can't
Presumptive.
prove it.
Yeah,
you can't prove it.
it.
You can't.
You can't
There's no
prove it.
testing for
Right.
it. That's what I meant when I said theoretical.
Right.
You
So-
got angry. Your face.
Well, because I believe, so now
No,
I want to.
All right, but this was a good conversation. I learned a lot from
Yeah,
you today.
me too. This was very good. I think we were both anxious about it because we're not.
Because we're not
feeling-
experts.
We don't feel like we're
yeah,
experts.
we're not
in
mold
this at all.
experts. Yeah,
So we will try to bring some people on for that.
for sure, we
Right.
will.
And,
Yeah. I'm trying. I have had very little exposure to mold medicine.
well,
I need more.
there's Not really much out
Other
there.
than,
Well, there
like-
are some workshops and conferences.
Yeah, but
you
like pap smears, you would look under a microscope and see.
know. Oh,
high
no, I haven't
fun.
had any of that. No, I agree. I mean, there are some very good conferences.
There's great
IE
conferences.
something or other. I can't remember the initials.
Right, there's that environmental medicine organization.
Yeah,
You
that's the
should
one I'm
join
talking
them.
about.
Yeah, they have.
Yeah.
They do have good webinars on,
Right.
on these topics for
Right.
sure.
Yeah, there's a lot of information out there.
Okay. All right. Well, let us know. I'm sure there's going to be a lot of questions on our
Yeah,
Patreon
yeah.
page. I hope that this conversation was useful,
And not too confusing.
not too confusing, but it's real and it's part of the overall illness in chronic and complex patients that's important to identify, to acknowledge, to treat. And that's what we try to do.
And then try again.
And try again.
And
Try
again,
again.
And again. So please send us your questions. If you have some topics you'd like us to discuss, send in some suggestions. Right?
Yep.
Okay.
All
Thank
right.
you very much.
Bye. See you next time.